Plan for spine surgery. Do you need only patience? This is a difficult question and cannot be answered in yes or no. Spine surgery should not be considered synonym to comprehensive spine care. It is one of the component. There are many. Same thing with the spine surgeon and spine care provider. Spine surgeons are not only surgery performer, but actually they are the care provider. And patience is one of the important stool in the armamentarium. Specifically, it doesn't remain a tool. It makes you so much, sweating that practically you get exhausted in the spine surgery for the good clinical outcome. It is not a disclaimer, but whole truth. In spine surgery, an additional patience is required. A clinical evaluation of the patient is important. Preoperative inclusion discussion, patient's optimization is extremely important, and perioperative planning is very, very important. And post-procedure care and empathy. Now, if you see, the patience is only one segment. There are many others. During clinical evaluation, you have to be alert. You are in busy OPD. Patient comes with the back pain, neck pain, limb pain, and degenerative spine is a Pandora box. Remember, all elderly patients are not patients. All degenerative changes are not symptomatic. I say it gracious aging, but MRI also may be gracious. It is not symptomatic. So treat the patient and not the MRI. Pick up the pathology causing symptoms and signs, and you have to be very, very methodical. Try to find out what are the symptoms generator. The common scenario in OPD, if you ask what is your problem, the patient tells the diagnosis, he has spondylitis. And when you ask where is the pain, he will say it is in back, severe one, doctor have suggested surgery and I have come to you for operation, you can see my MRI. And when you ask where is your X-ray, he will say had many, all are useless and only MRI could diagnose my problem. And he hands over MRI folder to you, don't get trapped into this. And you start seeing the MRI and you start seeing that what are the sites where there is a compression, and you have started planning also. And this is image treating surgeon. This may be disastrous. If patient has coexisting significant cervical stenosis, he can become quadriplegic if care is not taken in positioning the cervical spine. Never examine a patient without taking history. Never see images without examining the patient. In degenerative spine, you get 40% information by taking just good history. Thorough clinical examination adds 40% and investigation only adds 20%. Remember this. History taking in degenerative spine, it tells you the source of symptom. You want to visualize the pathology through the history, and you want to see the things when you are doing clinical examination. So patient can have back pain, leg pain, there may be neural symptom, and there may be peripheral neuropathy. So be aware about these mimickers. This is extremely important, and these elderly patients can have comorbid condition. You should be aware about the pain generator. This is extremely important. It is mandatory to examine upper limbs in all spine cases, whether it is degenerative lumbar spine. And you examine the patient from top to bottom, and you might find clue at some other place which the patient is not complaining of. So you have to go through thorough clinical examination, and neurological examination is extremely important. History and examination gives full clinical profile of the patient, and you must do it. What is this inclusive discussion? Now, in such type of discussion, you feel that it is important to do in these severe deformity cases. You must involve patients' relatives in this discussion and let them walk through you. They should walk with you. They should know what is the pathology and involve them in this patient care. Patients' optimization is extremely important. These patients are poorly nourished, build up their nutrition, they have poor pulmonary function. Try to do the extensive chest physiotherapy. They need supplements and infuse positivity. Say that he is going to be all right if he takes all this care. There are specific cases. Now, if you see, all these are the pediatric patients. And these patients, they have a specific problem. Their vertebrae are small, cartilaginous, they have poor tolerance for the blood, poor tolerance for the long hour surgery, and implantation issue in these cases, and there are issues of growth plates and differential growth. All these patients have different specific issues. Now this patient had multifocal cox, he had severe junctional deformity, this patient was having MDR, this girl is XDR is on Delamanin, and paraplegia with ball bladder involvement. Ball bladder involvement is a poor prognosis and implant cutout. Now, it is mandatory to do culture sensitivity and histopathological examination. Now, this boy, he has multifocal cox. In the limbs also he had this problem, he had neurological deficit. Junctional kyphosis. Now, here, it was implant issue, how to correct this deformity, and we had to make the custom-made pedicular screw, and which was a reduction screw, and we could get correction. Implant cutout. Now, dorsally you have good posterior element, and we should take use of it and use hybrid fixation, and it works wonderfully. Another case, almost 4-5 bodies are lost with deficit. Now here also we use the same thing. Never forget to have a good strut anteriorly, that is going to actually help you out later on. Planning during anesthesia, don't leave it to anesthetist. This is extremely important. This patient normal with the spondyloptosis. So here awake fiber optic intubation was done. Just by gentle traction it aligned and it fused, and there was no issue altogether. Planning during this ankylosing patient, if you are careless, then there may be fracture and neurological deficit. So one has to plan the positioning of this patient, and it could be corrected. Take advantage of this positioning. In spondyloptosis and listhesis, just hyperextension of the hip, it gives almost grade 1 to 2 correction, and you can get a good alignment. Now, patients with the severe compression, one has to be very, very gentle. There should be least violation of the canal, avoid jerks. The surgeon hand should always be supported on patient's body. Careful while handling the cord. You have to be very, very gentle so that there is no transmission of force. Keep the plant too ready. We used to do the transoral decompression, but in this case there was a tight opening, so we did extrapharyngeal and we could get correction. Now pulse of patient during last hour for your surgery, which is the 7th hour from the morning. Don't leave your patients, and you can do a good work. Be very gentle and alert during the sequential correction, and you can get a very good correction. The post-procedure care and empathy. Some day it may not be as rosy as the previous day. You can have trouble, and I had trouble 25 years ago. When I operated this patient had problem. He took full diet till 7th post-op date. On 8th day he had dysphagia and odonophagia. You see, this prevertebral shadow, and he started leaking. In search of leak, probably minor became the moderate one, and general surgeon could not find it. He put rice tube through it, and later on I lost this patient. It was a rough phase of my life. Went through all the available literature, and we could find this was a pressure necrosis. Mortality is very high. So lesson learned, just put rice tube. Most of the time it heals. If not, then you put the flap. Red flags, there may be fracture dislocation, and inherent injury to the esophagus, which is already there. So just my 2 slides. Only speed and number of kilometers is not important. It is more important to realize that you have chosen a right path. Sticking to a set protocol, having a pause, thinking about the etiology, identifying the red flags, making a judicious planning and executing it diligently usually gives a long-lasting result. In a crowded OPD or rows of indoor patients, you might not be able to spend extra time with each of them. Your empathic look, smile on face, and if possible, just a caring touch will add value to your all-along efforts of having patients in spine care. I thank you very much for your kind attention.